Yeah. Okay, there's Nehemiah. He's hiding up there. Okay, we're going to carry on. So I can just have your attention, please. We're moving on to another really interesting subject, something that we're all really interested in seeing come soon. To talk to us today, we have Dr. David Harriman, who's an assistant professor at the Department of Urology Sciences here. He's one of our kidney transplant surgeons. And he's going to be talking with Dr. Stephanie Chartier-Plante, who's a liver transplant surgeon and clinical assistant professor in the Division of General Surgery at UBC. And they're going to talk to us about normothermic regional perfusion. Evolution or revolution? Right.
Hey everyone. Welcome here. I'm just running from the operating room, so sorry about the attire. I have to go back after this, but that's life of doing surgery. It's fun and very rewarding. But Stephanie and I wanted to introduce the topic of normothermic regional perfusion to everybody. It's something that's happening in various jurisdictions around the world, and it's something that we might be starting to do here with our donor population. So it's really good that everybody's aware of it. It's good that we just give a brief outline of what may be coming down the pipeline. And we like the title "Evolution or Revolution" because donor surgeries, medicines, they all evolve. But if it's a revolution, then it's something drastically different than anything we've ever done before. So we're not sure. The jury's out on exactly what this is at this time. Neither of us have any major disclosures, but we do have some consulting grants that has nothing to do with any of this work that we're talking about today. So our objectives for today, we want to review different types of deceased organ donors with emphasis on the need to find solutions to improve organ quality. That's what we really want. We want to see our recipients get the best organs possible and do the best long term. It's a really rewarding career when patients do well. When patients don't do well, it's heartbreaking and it drags the whole team down, and we're all the team here, so we want to make sure that we keep morale high because it's a great profession and it's a noble profession and we do great work. We want to explain to you what normothermic regional perfusion is. Just a basic overview. We don't want to get too technical on it. We want to discuss some outcomes of it, specifically on liver and kidney. We steer away a little bit from pancreas when we did our final slide cut. We want to understand controversy surrounding the use of normothermic regional perfusion, and we'll address it as NRP. So if we say NRP, that's what we're referring to in this talk. We'll also throw out some other acronyms along the way. So, in transplant and talking about different types of donors, there's a whole jargon, and getting the alphabet soup of it all down can be challenging sometimes. We apologize, but it's just part of our daily lingo when we do all these abbreviations. So hopefully we explain that all along the way. And then we want to understand steps for what might need to happen here in British Columbia in order to implement something like normothermic regional perfusion. So we got to start with the basics of this. What type of organ donors are there? We're basically going to just focus on the abdominal organ side of things today. We're going to forget about the heart and the lung, other than just brief mention of them. But all of this applies to heart and lung as well. So you can have cadaveric donors or deceased donors. There's lots of different terms for that. We call it NDD, DNC now. We have DBD. There's lots of different terms that all mean the same thing, and it is so confusing. We'll try to make it as simple as possible. But you can have cadaveric donors that are either DBD or NDD or DNC. Or you can have cardiac death donors, which those are donors who don't meet full criteria for brain death, yet their situation is not compatible with life. And we feel that if you withdraw life support from them within a certain amount of time, they'll pass away from whatever catastrophic injury they sustained in their last moments. So in general, these numbers are sort of true. You can also have live donors. About 10% of all transplants are live donors. In our kidney transplant population, that's probably more like 1/3 of donors are live donors. 2/3 are deceased donors. In liver, it's much less as live donors. Toronto's the only center in Canada doing that right now, as far as I'm aware, for living liver donors. But here in BC, we have the expertise, and we might start doing that on a case-by-case basis for certain situations. And those are pretty much the only organs that do live donation currently, right now. There's this thing at the bottom here, controlled versus uncontrolled DCD. Uncontrolled DCD is not something we do in North America. It's something that's done in Spain, and it's very ethically charged and controversial, and I don't think we'll ever do uncontrolled DCD in our jurisdiction. Basically what that is if somebody has an event or a cardiac arrest in the field, the paramedics, they can actually essentially make them an organ donor right off the bat and get them all set up right in the field. So we don't do that, so it's very aggressive. It's a very aggressive thing to do. But controlled DCD is what we do here, and that's somebody who's been in the intensive care unit for a long time, their family's been talked to, there's lots of discussions along the way, there's lots of testing along the way to make sure that they truly are a suitable donor, and we feel that's ethically appropriate to do it that way. And that's gained widespread acceptance globally. So that's a basic overview of what we're talking about with organ donors. And when we think about organ donors, we think about, well, geez, why can't all of these organs be extreme quality? Why can't they all be, tip-top organs that I would myself want in me? And I tell folks all this. There's lots of different patient donor factors. So, for instance, if you're a young donor, if you're a 20-year-old person who unfortunately gets in a motor vehicle accident, no baggage in your medical history at all, you're perfectly healthy, your laboratory measurements are all perfect, that's a high quality donor. Any organ you take from that donor is going to be pretty good. But then if you go to the other spectrum, you got a 75-year-old patient with longstanding diabetes, high blood pressure, chronic alcoholism, COPD, heart failure, whatever it is, then we're starting to think, oh geez, can we take the heart from this donor? Can we take the lungs? Can we take the liver? Can we take the kidneys? What can we do in that situation? Because we know that those organs aren't going to stand as much of the transferal process that we do. And it's questions that we have like this that sort of drive talks like this. It drives us to want to be better, to try and make sure we're taking care of folks, because we do know that there's more folks who need organs than there are organs available. So we're always trying to figure out ways to make things better on this side of things. So it's sort of a neat talk, and this is really what BC Transplant does so well with us. We all work together to try and find solutions for problems like this. So again, this is just sort of the same idea, just looked at a different way. There's this NDD donor, DBD donor, brain dead donor, whatever you want to call it. Basically, this is a person who's brain dead, so we're allowed to keep that person on life support, and we retrieve the organs while that person's on life support. With the DCD, or now DCC designation of cardiorespiratory death, that's different. We extubate that patient, we take them off life support, and they have to pass naturally before we go in and we take those organs. During that period, from when they're extubated and when they're allowed to pass naturally, all of the organs in their body are getting some degree of injury that doesn't happen with brain dead donors. And it's that degree of injury that normothermic regional perfusion is trying to address. And there's the details of it is just mind-boggling confusing to know how much injury each organ group is getting, at what time points they're getting. It's probably the truth of it is, it's probably different for every donor in every situation. But that's the gist of it. So here in BC, I love these summary slides that we do here. You can see we did 160 deceased donors in British Columbia last year, and around 40 of those were donation after circulatory death donors. I keep harping on the donation after circulatory death, or the DCC donor, as Dr. Keenan will talk to you about later, because that's the donor that applies to normothermic regional perfusion. The brain dead donors don't apply to this talk that we're going to be giving you today. Okay, but you can see, I'm sure you guys have all seen these stats, and you all know the great work that we do in all the jurisdictions around British Columbia. But 112 liver transplants, that's world class right there. 353 kidney transplants, top 5% in all of North America right there. Pancreas transplants, 12 was our most we've actually ever done in a year here. So it was nine full simultaneous kidney pancreas transplants. We're trying to build that program up. And lung transplant, Dr. Yee's been spearheading that for years, and with all the support that he gets and everyone, 77 lung transplants, that's phenomenal. And the heart transplants at 22 is a good amount for them as well. So you can see all these organ groups are definitely working right now. And fortunately, as we keep getting more expertise, as we have more people in the field, our outcomes are getting better and better all the time in certain situations, but not all. All right, donor after circulatory death. So here's a little bit deeper. We've been doing this in British Columbia since 2008. You know, there was a lot of early articles on this topic saying that this is a novel source of new organs to be influxed, and now it's commonplace. This is something that's done everywhere in the world well, it's not true. That's actually not true. There's some jurisdictions that have not done that because they don't have the expertise to adopt this yet. But in general, it's slowly getting adopted where the expertise exists to do this, especially for kidney, liver more so nowadays. Lungs definitely are doing donation after circulatory death. Heart can actually do this as well, if you can believe it. It sounds contradictory, but normothermic regional perfusion can actually allow donation after cardiac death, heart donation, and you can do pancreas donation with this as well. So across Canada, it was 26.4% of all donors, and here in British Columbia, that holds about true. About 40 of our 160 donors, roughly, were donation after cardiocirculatory death. Okay, so we've really been doing this a lot. So this is kidney statistics. You know, we don't need to get into the nitty-gritty of the graph that's up there. In general, there's certain outcome metrics that we use in kidney transplant. We look at, you know, how long does the kidney survive? And we have terrible data to tell us how long kidneys survive in different populations in general. The general thought nowadays is that donation after circulatory death kidneys last about as long as brain dead donor kidneys. Generally speaking, it's about the same. A lot of it really depends on what that donor is starting from with their comorbidities. What is true for sure is donation after circulatory death kidneys have increased delayed graft function. So what that means is the kidney just doesn't work. If the kidney doesn't work, that patient needs dialysis. The minute that patient needs dialysis following transplant, their complications go through the roof. They get more fluid collections. They get more heart attacks. They get more volume dysregulation, which makes them really, really uncomfortable. So there's actual tangible outcomes to say like, hey, there's things that we can improve upon the whole DCD or DCC process. Okay, for sure. In other jurisdictions in British Columbia, oftentimes these donation after these DCD donors, they never actually are able to donate their organs. And this is traumatic for families. I'm sure there's many people who have talked to families before. Their families are expecting their loved one to be a donor for their senseless death to mean something. Because, you know, all donors are unexpected deaths when it's all said and done from the deceased donor standpoint. And these families are really hoping that that loss is going to continue and to benefit somebody. So when a donation doesn't occur, it's devastating for these families in certain circumstances. And that's something we always have to remember. And the financial cost, of course, if you're doing dialysis, if you're doing a whole bunch of other interventions for complications, you know, we always say kidney transplant in particular is the most cost-effective intervention in all of medicine. And that's true. If you can take somebody off dialysis and just give them pills for the rest of their life, you can increase their life, you can increase their quality of life, and you can save the healthcare system millions and millions of dollars with the volume that we're doing. But if you have a lot of complications or you need ongoing dialysis, that drastically increases the costs, and then the cost effectiveness of kidney transplant becomes more questionable at that time. All right, switching over to Stephanie.
All right, so similarly to kidney, liver transplant or liver organs coming from a donor after cardiac death also have a slightly worse outcome. There is a lot of paper. I didn't want to kind of focus on one particular paper, but I just wanted to put different examples of research that has been done, especially with DCD liver. But in general, they tend to have a lower graft survival with a higher rate of early allograft dysfunction, which translate into more problem with bleeding, longer ICU stay, and longer hospital stay, so a more costly transplant. There's also a higher rate of primary non-function, and unfortunately for liver, if someone has primary non-function, we have to retransplant and have to use another graft, which also leads to worse outcome for the recipient. The main issue also with the organs from DCD donor for liver is the higher rate of biliary complication. And the trouble with biliary complication is the liver might actually work right away, but 3 months later, the bile duct starts to vanish. The person comes with recurrent cholangitis, so infection from the biliary tree. They come with sepsis. They need to have either other instrumentation, like an ERCP, meaning a endoscopy to put stent across the bile duct if there is a single stricture, or sometime a permanent drain placed into the liver that kind of comes out at the skin. And if the ischemic cholangiopathy is too pronounced, then that will lead to a retransplantation. And we know that for retransplantation in liver, it has worse graft and survival outcome as well. In some center, they kind of come with outcome that are very similar to a brain dead donor. But how do we do that is that we're very strict about how much of that warm ischemia time we can allow for those DCD donor. And you can see that across country and per organs, the numbers are very similar in terms of how much functional warm ischemia time or how long we allow the donor to be without any support for. For liver, it kind of translates between 20 and 30 minutes. So for someone to be extubated and then to pass within that 20 to 30 minute periods and be cannulated and the organ perfused with the cold solution flush, this is not that much of a long time when you think that there has to be a standoff period of about 5 minutes. And sometimes the donor also have to be transferred from the ICU to the operating room. So it doesn't leave a lot of time to do that. For kidney, lung, and pancreas, they are a bit more permissive organs. They don't have that trouble with ischemic cholangiopathy, and that time varies between 60 and 120 minutes, depending on the countries and who you talk to, and how also other donor factors. Some of the donor factors that can influence DCD outcome and also can help us decide how long do we want to wait on that functional warm ischemia time. So the age, is the donor stable or not? If there be a long period of instability or long period of arrest might also factors in. The BMI is really a surrogate for steatosis for the liver. So if someone has high BMI, we can expect maybe some fatty liver, and that will lead to more trouble with the liver transplant. Also, the location of the withdrawal of a life support measure. So if we're allowed to withdraw in the OR and the patient is already ready to go ahead with the organ procurement, or if we have to withdraw somewhere else in the hospital and we have to factor in that transfer time between where the patient is and the operating room. We also talk about the functional warm ischemia time, so how long it takes for the patient to pass. And we don't know, a different center use different criteria. We don't know if that time starts from the time of extubation or if the donor is fairly stable for a long period of time. If we just start that functional period when the systolic blood pressure reach 80 or 50. And there is a lot of debate in the literature about what exactly consists the functional warm ischemia time. There's also some debate about pre-arrest anticoagulation. Some jurisdictions allows to give heparin, some don't. And also the whole cold ischemia time, so how long the organ will be in the box before they can be implanted in the recipient. There's also some recipient factor. You have to think as in whom you're putting that organ in. Is it an older recipient? Is it someone that's going to take a lot of time to remove the liver? And then that's going to increase the cold ischemia time. And this is someone who is very sick and who cannot really tolerate an organ, who's going to have a little bit of a rookie start or some delayed graft function at the beginning. So that kind of thinking comes into practice when we're thinking about a DCD offer. I have to look at my recipient and say, well, in whom can I put that liver to try to have the best chance of having a good outcome? When we think about traditional DCD procurement, so what happened is that in the ICU, they withdraw care, and then we wait in the OR. In the OR, the team is ready, we're scrubbed, we're waiting for the patient to pass. Once we know that the patient passed, there is a 5 minutes ends-off period, and then the patient is brought to the OR. It's on a stretcher, not in the operating table. We rapidly kind of undress the patient, prep the patient, and then we make an incision from previous to Xifi, and then rapidly we need to find the aorta and then flush the aorta and put our cannula, and then after that we're going to cross clamp. In that whole kind of hurried time, there is also an increased risk of organ injury. And then once the organs are perfused, and we can cool them with ice and we can relax a little bit, but there is still some data that shows that if you take too long to retrieve the kidney or the liver or the lungs, then there will be extra damage happening. So you really want to be kind of very fast, and they call it the super rapid technique for that reason. So when we think about DCD, so right now, if we want to improve the outcome, what we're doing right now is really strict donor acceptance criteria and try to optimize the withdrawal process to minimize time with a shorter time to transfer the patient, for example. What we would like to do is, well, during retrieval, can we reestablish some oxygenated blood supply after the asystole period to allow the organ to recover from that initial insult? And then also, can we road test the organ before we actually accept them for donation? So right now, kind of last summary of that two different pathway. So the donation after brain death, which wouldn't change, and then for the donation after circulatory death, what we would like to do is the NRP. There is other avenue kind of after the organs are removed. They can also have some perfusion, but that's kind of separate per organs. So that's more costly and also more challenging to do because each organ needs their separate pump. So that's kind of led into what is normothermic regional perfusion. Well, it's not really a new technique because there is report of NRP from Spain and Taiwan in the 1990s. In Spain, they use for uncontrolled DCD. So patients that would come to emergency in cardiac arrest, they would put them on ECMO and then kind of test the organs and have sometimes try to buy sometimes while they can do the test to see if the patient could be an organ donor. Interestingly, there was a program of NRP in Michigan that was abandoned in 2004. Didn't think it would be something they would like to pursue, but they've done it in the States kind of more than 20 years ago. Where it really kind of picked up is in Europe in the 2010, a lot of programs started to increase and to do NRP, mainly to try to improve the yield of abdominal organs. So the UK started their program in 2011, Spain started to introduce NRP in 2012, and then slowly other countries kind of followed through. And some countries like France and Italy have made NRP mandatory for all DCD. In Italy, they actually have a no-touch period of 20 minutes. So they wouldn't want to use DCD organ in that context, but if they do NRP and can test those organs, now they actually have good series on NRP. About 2020, the US kind of came back to NRP, but with a thoracoabdominal or TA NRP approach for DCD heart, and that kind of drove the need and the desire for NRP in the States is really the heart transplant program. Right now, kind of in this situation, so the NRP is mandatory in Italy, France, and Norway, and it's permitted in Spain, UK, Belgium, Netherlands, Switzerland, and in the US as well. So there's a few kind of terms I mentioned that I wanted to explain a bit more. ANRP, TNRP. So ANRP is abdominal normothermic regional perfusion. So what we do is we want to perfuse the abdominal organs only to try to see how they're going to work. And then we want to clamp and we don't want to perfuse the hearts or the lungs. In TNRP, or thoracoabdominal normothermic regional perfusion, the central vessels close to the heart are cannulated, and the cardiac activity can be reinitiated to allow DCD heart donation. We wanted to stay out of that TNRP debate for now and focus more on abdominal NRP, as this is kind of Dr. Harriman and myself wheelhouse there. So the difference between an NRP procurement and a regular DCD procurement. So still, the patient withdraw cares, there is a asystole, and then there is a standoff period. What happened after that is that we cannulate the aorta and the vena cava, similar to what we would do with a DCD procurement, make a medium sternotomy and cross-clamp the distal aorta. Once that's done, we can open the aortic arch and put a cannula to confirm the absence of brain perfusion. And from that moment on, we can start the bypass or the ECMO machine, and that lasts about 2 hours. Some centers describe about an hour, up to 4 hours. The average, most centers do about 2 hours of NRP. While you do that, you don't really touch the donor, but you kind of let it, you do blood gas and biochemistry samples every 30 minutes to 60 minutes to kind of road test the organs. You're looking at seeing if the kidney is making urine, the liver is producing bile, if the lactate is clearing, if the AST/ALT liver function is decreasing. Once you stop NRP and you decide about acceptance of the organ, then you stop the bypass machine and you just cold perfuse using your cannula, and then the rest of the donor goes like a regular brain dead donor. So what about the lungs? So we won't be doing lungs? No, so there's a paper and a lot of documented where patient did abdominal NRP, and you can see in the picture that the organs are pink in the abdomen, so the liver is well perfused, the bowel is well perfused, but they remove the lungs in a super rapid technique, the same they would do with the DCD lung, with meticulous dissection, very good hemostasis like they would do in a live patient doing a pneumonectomy, and they clamped all the vessels to preserve the perfusion in the abdominal organs. So you can still do an abdominal NRP only and retrieve the lung separately to preserve outcomes with both organs. So benefits of NRP. Why do you want to go through all that trouble of doing a bypass machine in the OR? So the main thing is to expand donor acceptance criteria, and also allow us to test the organs before we transplant them. It's also an intervention that impact all abdominal organs. Rather than the separate pumps for each organ, we can test and use it for the pancreas, the liver, and the kidney. So also the procedure is much more unhurried at this point, and that decrease the risk of injury to the organs. It's also allowed the organ to recover from that ischemic injury, because then they have oxygenated perfusion for a few hours before they are retrieved, similar to a brain-dead donor. This is kind of looking at the UK program, which has been ongoing since 2011. When they look at their DCD donor and their recovery, so using NRP allowed them to recover 3.3 organs, so that's an increase compared to the standard super rapid technique. And the liver had threefold chance to be transplanted, the kidney 1.5 times, and the pancreas 1.6 times. It did decrease the hazard of graft failure for the liver and decrease the risk of DGF by 35% for the kidney, with a better eGFR at 12 months. So they thought that NRP increased organ utilization and improved transplant outcome when compared to the regular DCD technique. This is a similar paper from Spain. When in Spain, they're allowed to cannulate either before life support or after the declaration of death, as I explained earlier. They show that it decreased the risk of biliary complication 8% versus 31%, and the risk of ischemic congiopathy to 2%, which is very similar to a brain-dead donor, compared to 13%. SRR is the standard rapid recovery technique. The graft loss was also decreased. This is a graph from colleagues at Baylor where I did my transplant fellowship when they started NRP, and it kind of showed the evolution of their NRP technique. What I wanted to point out is what's in that green circles. They started with DCD criteria for liver that are very similar to what we're using right now for our liver acceptance. So less than 60 years old, functional warm ischemic time of 30 minutes, and we start the functional warm ischemic time when the saturation of the blood pressure reached 80. They kind of evolve, and you can look up, it's kind of every single NRP cases they did. In green were the cases they were transplanted. In blue, the cases that exceed the functional warm ischemic time. In red was the cases that were declined. And at the end, now they're using a total warm ischemic time of 90 minutes. The reason why they use 90 minutes is their hospital don't allow them to go past 90 minutes. It's from the US. But they use a functional warm ischemic time of 30 minutes from a systolic blood pressure of 50. And I would say that most of donors, when they reach a systolic blood pressure of 50, they pass pretty quickly after that. So basically, they told me that we test NRP on most donors that passed within our 90-minute period, basically, and see if we can use them. It also shows kind of how they progress from an in-house donor program to now they have a fly-out program when they bring their NRP staffs and their NRP machine to other hospitals to allow more organ recovery. This is also from the UK. When you will look at organ acceptance, in A is the liver and B is the kidney. So in black is the brain-dead donor, where you see from the first kind of time is where the organs were offered, accepted, retrieved, and then transplanted. In red is when NRP was used, and in green is when NRP was not used. So you can see for liver especially, but also for kidney, the use of NRP increased the number of organs that were offered and transplanted. From the UK as well, so kind of the progression of the use of NRP, we can see that it's not something that they went from 0 to 100 in 1 year. They kind of slowly built up with time. They did 2 their first year, 3 their second year. In 2019, they've done 37 abdominal NRP and some TNRP as well. This is...
Thanks. So kidney outcomes in NRP. They're a little bit more mixed, I think, than in the other organ groups, because kidneys do pretty well regardless of what we do with them. And I think one important thing to look at when we're showing you all this data is it's hard to really know how this data would perform in our province, because we're a little unique. We have very, very low discard rates of all organ procurements we do. We definitely have strict criteria for what we accept with DCD, and NRP might allow us to loosen up that criteria a bit. That's one of the advantages of NRP for us. But this idea of a lot of discard is not something that we see in our province for the most part. But we definitely have DCD donors that we don't get organ utilization out of. And again, that's a devastating thing for families, for providers. It's a time, resource intensive thing, and it's a big deal. So kidney outcomes, these studies range from 2018 to 2021, and most of them are relatively small numbers of patients, but they are comparing the brain dead donor versus the donation after cardiac death super rapid technique donor versus NRP donors. And, we said for DCD, DGF, delayed graft function, is an interesting outcome. And if you look at the delayed graft function situation, the first line is NRP versus DBD is 7.1% versus 4.9%. That's pretty great because all DCD donors outcomes is about 25 to 40% delayed graft function in our general DCD population. But when you actually go sort of dive into it a little bit more, it's hard to know if it's actually clinically significant for decreasing delayed graft function, but the trend is sort of saying it decreases delayed graft function, and if you decrease delayed graft function, you're going to decrease patient morbidity associated with transplantation. And the idea is that these organs are going to last longer and patients are going to do better over time. So the data for kidney is a little bit mixed, but it's still there, and there's certainly no harm in doing NRP for kidney, it seems. So that side of that's really important to know. Back to the liver.
So for the liver transplant, you can see there is multiple cohort. The biggest one is from Spain, the smallest one from Norway. The main thing is looking at the rate of ITBL, of the ischemic complication, which the largest one is 10%, and their 1-year graft survivals, 92, 93 to 100% with the 8 patient in Oslo, is pretty good. So that's the main thing for liver about NRP, is the decrease in the ischemic complication, ischemic biliary complication, which hasn't been showed in any other modalities. You can also see that, interestingly, their donor age. Some centers go up to 71-year-old donors for liver for DCD, and their total donor warm ischemia time kind of varies as well. One of the centers goes up to 96 minutes. So it's great to implement a new technology, and you'll tell me, well, how much does it cost? Well, most of the cost of the NRP kind of comes from the use of a perfusionist to run the ECMO or the pump circuit. Most of the NRP donor, because we're doing a pump circuit and some of the blood is going through that circuit, need a blood transfusion, somewhere between 3 to 6 units. Also the OR time, which is now similar to a brain dead donor, so about 3 hours, 3 hours of OR time, and some extra lab and point of care testing, including doing more frequent blood gas and lactate to test the function of the liver. 2 of the paper in the States I've looked at the cost of NRP. So for Crum, it says this is about $6,000 US per case for the disposable related to NRP. And from the Baylor group, they think that an NRP costs about $4,000 more US than a regular DCD with super rapid technique. What can we compare it to? Well, if we look at also other kind of perfusion techniques, so when I talked earlier about single organ machine perfusion, there is 2 companies. Transmedic is one in the States that now do organ procurement and kind of will pump the organ, package them, and bring them to centers. Per organ is about $46,000 US to have a Transmedic organ. Organox is the other pump. And Edmonton has been using it under research protocol for quite some time, and they went over their cost of a case, and they thought that a machine perfusion run added about $18,000 per run for their organ in the Canadian context.
The ethical controversies. The only thing I'll add to this slide is right now for a lot of DCD organ procurements, we use cold perfusion machine pumps, and the cost of those, and I might get this wrong a little bit, we could definitely get the numbers, but it's about $5,000 every time we use that. So if we were to do NRP, we wouldn't need to do the machine pumps anymore because that would be more like the brain dead donor. So the cost would probably be a bit of a wash with how we do things. The real downside for NRP, and this is the one that our hospitals are going to have to get around, is the OR utilization time. To tie up an OR for an extra half a day of operating is no small feat. That means elective cases may get canceled if we don't have the staff, and with nursing shortages, with perfusion shortages, there's a real personnel issue to implementing this in British Columbia, and we're going to talk about that soon. But there are ethical controversies. This is not something that people haven't spent long and hard about thinking, is this the right thing to do for patients? Well, what are some of those controversies? Well, let's start with what the American College of Physicians said. They said ethics. They had a paper, a consensus statement paper. And basically what they said is they have a statement of concern. They were concerned that we're going to reanimate people by resuscitating them, by starting their circulation up again, and that's not compatible with allowing somebody to die peacefully. So that was the controversy from the American College of Physicians. And the American Society of Transplant Surgery came out and said, hey, wait a second. No. We're the experts in the field. There's no controversy with that. We're not resuscitating anybody. We're just perfusing organs is all we're doing. And we're doing that for the purpose to honor patients' wishes, families' wishes, so that we can get maximum organs transplanted from that patient. And so there was a little back and forth on this, and this is just sort of one back and forth out there. Each jurisdiction has this same sort of out of talk, but the bottom line is this is happening all over the place. So it's passing most jurisdictions ethics standpoint. Public opinion on NRP. So this was a thing given out to a survey given out to patients and families and technicians and organ procurement organizations like BC Transplant or in the US. And, basically what it said was that the general public actually didn't really like the idea of NRP and didn't, it's hard for the general public to really understand what NRP is, but when you don't have acceptance from the broader community over what you're doing, then you have to sort of think, how can we educate people on what's going on here? And when is the right time to roll something like this out? And sometimes there is a little bit of, and this is a paternalistic view, but sometimes there is a little bit of how much do people really need to know sometimes too. But at the end of the day, we're in an information age, and ChatGPT can tell you all about it right off the bat. So we do need to make sure that people are smart, and we got to make sure it's if we do implement it here in British Columbia, we have to do it in a way that we have buy-in from all stakeholders. So this was just an early article saying that there's not total buy-in from everybody who they polled. There's the dead donor rule in British Columbia. This is what guides organ donation. You're only allowed to take organs from somebody who is legally dead. And Sam Shimmy, and we're going to get a really great talk from Dr. Keenan about this later, about, we won't go into a lot of detail on this, but there are concerns with NRP that we're violating the dead donor rule. And it's mainly those same concerns that the American College of Physicians came up with, that we're going to be reanimating people, we're going to get collateral blood flow, and that's not compatible with the dead donor rule. We're not totally governed by the dead donor rule in British Columbia or in Canada, even though some people will say we are. We're not totally legally bound to it as much as other people say, but that's a point of controversy as well. And certainly, we all believe in only taking organs from patients who are truly passed away. But as you'll see in the talk later, there's a little changing definition of death. When does death occur? How soon could we go in there and take organs? There's a lot of work being done on that right here locally right now. So this has to come to the cerebral blood flow. So here's the challenge technically with normothermic regional perfusion. you have this, on the graph on the left, you have the brain, you have the brain stem, and then you have the abdominal and thoracic aorta there, the arch of the aorta. So you almost have a posterior and an anterior circulation that can all lead to the brain. The anterior circulation, the aorta and the great vessels, when we're doing the procedure, those are very easy to access for us in most patients. So we can definitely stop blood flow from going to the brain in the anterior circulation. The real concern is the posterior circulation, the spinal cord. There's lots of blood vessels that go into the spinal cord that when you're doing NRP, there could be collateral blood flow up into the spine. So there's techniques that we're all going to have to learn and be proficient in that actually stops spinal cord blood flow up into the brain. But you can tell that takes a lot more expertise, takes a lot more time, and it's very meticulous work. But that collateral blood flow through the spinal cord has been one of the overarching ethical controversies of NRP. So I mean, there are studies that have looked at this right now. You can see the UK data there. There was no proximal aortic flow in any patient and no pressure or flow on brain perfusion scans. So these are non-invasive scans that they're doing, but in their small limited series, they didn't see any collateral brain flow, but theoretically, it is absolutely possible. Okay, other controversies. These ones we'll just read out here. Will expanding DCD donation eligibility disproportionately affect the stigmatized population already burdened by the nation's substance abuse pandemic? So again, this is part of the dead donor rule, and it's, patients who come in overdose, will we be more aggressive at trying to get those? That's what this statement is saying. And certainly us as providers of anything to do with transplantation, we always have to uphold, the standards that we do things, even if there is new technology being implemented. So I don't think that's as much of an issue here, but that's certainly a United States issue that's been spoken about. Point 2, if donor and recipient family members are not made aware of the full details of this protocol, this could lack transparency and could damage trust in the system. So this comes back to that survey. The general public doesn't totally support this use right now. So if the general public's not supporting it, it's going to be hard pressed for us to support it as well, because part of that transparency may be concerning. Now, we do have some data with our own ICU here. They've already been talking to donor families about invasive monitoring at the time of death. They do non-invasive monitoring at the time of death, and they've really had limited pushback from many families about that. So as long as we educate these families to a certain degree, this is probably a barrier that we cannot surmount. Point 3, whether the alternative to ex situ machine perfusion is ethically acceptable. Okay. This is the point that the American College of Physicians makes. There is a large and ethically significant difference between perfusing an organ versus perfusing an individual. Okay, so in NRP, we're just perfusing the organ. The ethical concern is that you're perfusing the individual. And if the technique is done correctly, it's just perfusing the organ. But that is very provider dependent, and we're going to have the expertise to back up such a tool. So, I mean, the ethical principles in NRP are stuff that we should always adhere to. These are stuff that in any basic class you've always seen. We want to respect the people with autonomy. We want to do good. We don't want to do harm, and we want to make sure it's a fair process for all. But we also know we don't want to see people die on the wait list. And we also know we don't want to see families who are really hoping that the donation occurs. We don't want to see their loved one pass without having a chance to donate. So this could alleviate both of those concerns potentially in certain circumstances, not all circumstances. Okay?
So how do we move forward with implementation of NRP in British Columbia? Well, I think a lot of the ethical controversy comes with the difference in philosophy of implementation of NRP. While in the US, they went directly for thoracoabdominal NRP, tried to basically reanimate the heart, and the abdominal organ were there as a bystander with better outcome. While in Europe, they use abdominal NRP to increase the abdominal organ yield. I haven't seen any paper or controversy coming from any European center, and I found it was interesting that most of the ethical and medical controversy all come from the States, where the approach used was really to start with thoracic NRP rather than abdominal NRP. So I think we should kind of take a more European approach to our NRP program and start by doing it to increase the yield of abdominal organs. It starts with having stakeholder supports with BCT, the intensivists, making sure the bioethic are also supporting of us. We need to make sure the OR, the retrieval surgeon, the perfusionist, and the blood bank is all supportive of this. And putting a team together, we need to kind of discuss with the people we usually do organ donations with, so our ORAs, our SRI, but also involve nursing in the OR, involve perfusionists, which we need to run the bypass, and then the retrieval surgeon. We need to make sure we have all the additional equipment, and then make sure we have protocols, and then do some training. Make sure that everyone is aware that we're going to be doing NRP, look over the theory behind NRP, and do some dry run and some practice to make sure that the first time we do it well. And then we have to try it and do a first run of NRP. Start slow, and then after each, kind of do a little, I love quality improvement, so do a little quality improvement and see how we can improve for the next run. And then after that, when we have a program that's established in one hospital, likely at VGH, then we need to think about how can we expand so all the families and donor can benefit of NRP. We can do it on the most donor that we can do to be able to transplant and use the most organ we can. We're looking at other program that has similar kind of experience. So I think the Edinburgh experience is a really good comparison for us rather than looking at the US experience, where they kind of started with 2 surgeons, 1 perfusionist doing NRP when they were available, and then they kind of obtained support from stakeholder, developed some protocol, equipment, did some training, some recruitment. They were able to expand their criteria, and now their NRP program in the UK has really picked up, and they are able to, they had funding from the government to use those perfusion technology. So I think their model is probably very similar to what we're hoping to do in British Columbia. So I think NRP is coming soon in Canada. Ontario may have already performed some NRP procedure. In BC, we hope to start, hopefully this summer, under a research protocol and ethical oversight. I think it's going to be challenging logistically, but I think it will have a significant benefit from all the patient, and also has the potential to increase the nation, especially on the liver side. That's all we got.
Okay, thank you so much. That's something that's hopefully coming not too long from now, but yeah. So there were some questions about the availability of perfusionists, but I think you sort of addressed them. I don't know if you have anything more to add to that, but yeah.
I just know that it's a real concern within the hospital and within our province in general. Each hospital is understaffed with perfusionists, especially, I mean, perfusionists are vitally important for any cardiac and thoracic surgery that's being done, and also for some other surgeries. So they're really in-demand folks. And just getting them trained, making sure that there's enough of a workforce there. We're a skeleton crew at Vancouver General Hospital with perfusionists. I know St. Paul's has the exact same problem. And that is going to be a barrier to implementing this, no question about it. We need to, but I mean, we have deficiencies in all aspects of our healthcare system. We're always we have all these great people in the room who are probably not. Everyone in this room's probably been asked to do more with no further compensation, with no nothing. I mean, that's our system, unfortunately. Is it expects the world-class program on a shoestring budget sometimes, and I know if you love what you do and if you really believe in it, then sometimes it's worth doing those extra tasks. So this would be an extra task for perfusionists at this point.
Okay, thanks, Dave. So does the use of NRP mean the withdrawal has to occur in the operating room?
That's a good question. I think both can be done. I think under the research protocol, I don't want to go into detail in the research protocol that hasn't been fully public. But I think with the test on brain perfusion, we might have to withdraw in the OR just because the amount of equipment under the research. But after that, once that is over and then everyone is comfortable with NRP, then I think it would be the same. It could be the same process as current DCD, meaning we would join the ICU, have the 5-minute no-touch period, transport the patient hopefully very quickly to the OR, and then we can perfuse and start the NRP. As I mentioned earlier, Italy has a 20-minute of a no-touch period. So I think if you add all our thing we need to do with transporting the donor and everything, it still comes down to less than that 20-minute period.
Thank you. Do you feel that the average family member is capable of understanding the risks of reanimation of the brain to provide consent for this process?
I think we'll be able to prove that the risk of reanimation of the brain is 0. I went to a recent meeting on NRP. We had a neurosurgeon kind of talk to us about brain perfusion, and they said, well, if there would be brain perfusion through those collateral, it will be less than what you would have like in a stroke brain that has no chance of recovery, in the part of the stroke that has no chance of recovery. So there's a lot of if and if and if, but we're hoping to kind of prove in an even better way than it's been proven in BC, which would be a word first, that the brain perfusion is really 0, and the chance of reanimation is actually nil.
Thanks, Stephanie. Next question, would you be able to utilize donors that take greater than 2 hours to pass?
So the answer is yes. And exactly how far you could run it out, it's hard to know. I mean, even right now, we could actually run out longer than 2 hours in certain circumstances for kidney. For liver, we do have strict timelines on those, but even those could be fudged. You know, that young, perfect, healthy donor versus the old comorbid donor, those are different things, and one time doesn't fit all. It's just a number we sort of come up with. But really and truly, the main reason we don't run out longer are logistics and tying up resource right now. So that's a big issue with NRP, no question about it, is the amount of resource we're going to tie up with something like this. It's basically going to tie up an operating room for the entire day and a team for the entire day, perfusionists for the entire day. It's a big deal.
Thanks. Kim, you had a question?
2 questions, actually. One, I was just wondering, how do you see going from the warm ischemic straight to cold versus the improvement if going warm ischemic to normothermic perfusion for that 2 hours? How does that recover the organ, or what does it actually do different than going straight to cold?
So it does actually recover the organ because it's oxygenated perfusion. And then for the liver, for example, then you're testing the AST, ALT, and the bile production. You're also looking at the lactate. You don't necessarily expect the lactate to have a huge drop because you have some part of the body that are not perfused and they'll still produce some lactate. But you always wants to see that the lactate stays the same or has a general trend down. So seeing that is kind of reassuring that the liver will function when we put it back. The NRP is mostly for the liver, I will be honest. The kidney is a nice bystander and they take advantage of it, but there is some organ recovery just from being oxygenated for 2 hours before that other period of cold ischemic time that's also going to contribute to the organ damage. So if you have a DCD, the warm ischemia plus the period of cold right away just going to compound that factor and that damage to the organ.
And sorry, my one other quick question, hopefully, is all the equipment you're talking about, I get if we're going to do it at VGH, but if we're taking it to other hospitals, how much are we talking about transporting?
Well, I think that will be kind of one of the logistical things to sort out once we kind of want to expand outside VGH, is it easier for everyone if the donor are transferred to VGH and telling the family that, well, with DCD donor, it's better if the donor are transferred here because then we can do an RP and that's increase the chance of using those organs, or we can do them locally, but then we have to come back to those very strict criteria. We can put the liver on the pump, we can put the kidney on the pump, but those are not as good as NRP right now. Or can we do, a lot of jurisdictions have portable NRP right now. With a portable, they use their own bypass machine to not use any hospital resources. So you can pare it down with the point of care testing and the bypass machine, the rest, the cannula, it's kind of all the stuff we usually use. So we could decide if we want to make it pared down to a portable one, or if we want to use the local machines. We said, well, we're going to do an RP when they have cardiac surgery, so Victoria, Kelowna, and Vancouver, or everyone comes to Vancouver. So I think that will be discussion when we're in the expansion phase, once we have the proof of concept.
I'll just answer the first part of it just a little bit more too. Is the first part was, you go from warm ischemia to the NRP versus now we go from warm ischemia to cold ischemia, and what's the benefit of that? And basically, transplant is all about accumulative injury over time. That's what happens. The donor in the intensive care unit has sustained some injury to get them in that situation in the first place. They were often on lots of antibiotics. They've had tons of resuscitation. They've had their organs have been damaged in some way just from whatever event they happen. It's very rare we don't get totally undamaged organs from donors. Then when you talk about DCD, now you get the warm ischemia time, and depending on how long you run it out, and again, it's arbitrary for how long you go. How long you run it out, that's going to get increasing injury. And different parts of organs are more susceptible to injury. In the liver, it's the bile duct. In the kidney, it's the ureter. Those are more susceptible to warm ischemic injury over time. Then you go to cold ischemia. That's when you do cold storage. We either do that on pumps with kidney or we do it in a box. That gets additional injury over time. The longer you let injury occur, the harder it is for those organs to recover from injury, the more scarring those organs get, and the worse those patients do over time. The idea with NRP is to sort of break that cycle. Because even right now, it's not uncommon for us, I'll take the kidney for example, it's not uncommon for us in a patient who has a tumor for us to clamp the kidney for an hour. We cut out the tumor, we let the blood flow go back in, and that kidney has no ill effects of that over time. It's not uncommon for us to do that. But if we were to do the whole standard storage technique that we do now, that kidney may actually not even be able to come back in that situation. Okay, so the idea is to limit the amount of time that injury is happening to that organ. And if you have 30 minutes, an hour, and then you can reperfuse it, reoxygenate it, then the idea is that that's going to create, it's going to mimic a normal environment where the organ doesn't think it's, being pulled out and stored and all the other things that harm it. So that's the idea with NRP, is just to decrease the injury.
Thanks, David. Next question. Do you know what sort of public engagement was done in Ontario and what it showed for them to go forward with their NRP cases?
So I'm not sure if they're gone forward yet. I think you think they've gone forward. I know there is a big pan-Canadian CAIHR grant that's been submitted with some people from Ontario. BC Transplant is part of that. And part of the grant is to try to create material and try to engage the public to basically have their opinion and to have things that can be done kind of similarly across Canada. So hopefully that should come as NRP is being implemented in Canada.
Yeah, they have done cases. They've all gone through their local ethics boards and through their organ procurement organizations to allow these things to occur. But I don't know the actual outreach that they've done. I don't think it's been super extensive at this point in time, unfortunately. But I think there are plans to make that happen.
I hope I understand the next one. Is there a study for living-related donor, paired kidney programs, DCD and NDD donor kidney transplants, and what does the average transplanted kidney last? So I guess they're just trying to talk about which. Yeah.
Yeah, I think I get the question. I think we're always looking at outcomes. We always want to know how we're doing. We definitely want to know what our living donor outcomes are. We want to know what our deceased donor outcomes are. We really want to know these things because we want to know, are we hurting people by doing certain things that we're doing, or are we actually helping people out? So yeah, we're constantly looking at outcomes research is a big part of transplantation. And that's something that's always going to be here to stay. And what was the second part of the question?
I think that was just trying to get an idea of the relative survival of the kidneys of those different types of donors.
So what I tell folks is I say the average deceased donor kidney lasts about 12 years. The average living donor kidney lasts about 15 to 20 years. That's usually what I tell folks in clinic. But I also say, the theme I've been saying over and over again is it's a spectrum of donors. A young, healthy donor will probably last as long as any living donor. From a deceased donor, that 20-year-old in a car accident with no comorbidities, that kidney will probably last 25 years. Whereas, you know, a living donor from a 72-year-old mom to a kid, that kidney might only last 12 years. And these are averages, so some kidneys will fail sooner. You know, I have a whole spiel that I talk to patients about in clinic. I mean, our 1-year outcomes, all comers for kidney, are about 94% graft survival at 1 year. Patient survival at 1 year is about 96, 97%. So we do have about 3 or 4% of our kidney transplant patients that die within a year. In liver, it's about 10% of patients die within a year of the transplant. Is that about right? It's about that. So I mean, we have all these stats, and outcomes research and transplantation is here to stay, and it's vitally important to inform us what we're doing. That's what I'd say.
Next question, it's several existing DCD policies have a no CPR, no ECMO statement within them. How do we change intensivist perception? So this is more like what the ICU docs and how.
I think the intensivist perception has been kind of the hardest part for, I think, Ontario that have been going forward with NRP way before if I think their intensivist was the main roadblock. I think one of the main thing is that landmark paper by Shami and Al, which is a group of intensivists when they kind of revised the Canadian guidelines for the determination of death, so that all death kind of at the end are from neurological death, either, and the neurological death can come from absence of brain flow or can come from cessation of circulation leading to neurological death. I think we're fortunate in BC that at VGH our intensivists are very supportive because they're at the forefront of brain perfusion research, and they're already doing some work in that area. So I think the VGH intensivist population is not the population we have to convince, but we're hoping that if they are convinced and we can make it convincing with our study, then they will be able to convince the rest of the intensivists in the province after that to hopefully change those policies and allow NRP to be done on as many donors as we can.
Thank you, Stephanie. Next, there's a couple of people who have asked about in the area of engagement, specifically engagement of Indigenous people in this, and the spirit of cultural safety. Just something to consider.
Yeah, I mean, that's an incredibly important point. And, you know, we could expand it from Indigenous peoples as well, like culturally vulnerable peoples, you know, people who have just come over to Canada and may have different customs in the places they came from. I mean, there's a whole bunch of layers of potential vulnerable populations that, you know, you do have to have a deep exploration to make sure you're not unduly harming these folks and to make sure that that those groups really understand what's going on as well. So yeah, this will be part of an engagement strategy, and exactly how that rolls out. I don't know if there's a specific template for that, but it's going to be forums like this to get the word out there. We do have different patient engagement forums that ideas like this can get introduced. And certainly there's research protocols where, you know, research or patient partnerships are becoming huge these days. So those are going to be things that are going to have to be sort of grant funded projects over time to look at these things. For those people who do research, this is a really exciting thing to sort of get on board because it's new. So there's a lot of work to be done.
I think to add to that, I think as we're doing NRP under research protocol that's been approved by ETHIC, I think it would be interesting to kind of involve other communities and see how we can make sure when we present NRP or when BC Transplant present this to the donor family, if they are from a different cultural background, and to make sure that it's presented in an appropriate way that doesn't clash with their beliefs and cultures. So I think that would be something very interesting to develop in the next year or so.
Thank you. There was just a clarification on what VGH is planning to start with, as far as it's the abdominal versus.
Yeah. So in terms of clarification, we're planning to do abdominal NRP only, so perfuse the abdominal organ only. There hasn't been much interest from the heart program right now to do DCD heart, mainly because their wait list is so small and they have so many good brain dead donor that they don't see right now the need to expand their criteria on DCD heart. So I think we'll hope to start with abdominal NRP only. If we do have to retrieve lung and the same thing, the goal will be to do abdominal perfusion of the organs with the super rapid technique for the lung, so have all those clamp in the chest, and then they can retrieve the lung with meticulous hemostasis while we perfuse the organ. So that should not affect the lung procurement in much way, except that they will have to clamp everything rather than kind of leaving things open as we're doing now. we're very fortunate because we work with the same team of thoracic surgeons. So I think when we can kind of come the time to start and kind of go over practice run, it will be easy to engage the same group of surgeons and have them kind of participate in that rather than working with a different team every time.
Thanks, Stephanie. I think I'll make this the last question. So, what is done to assess whether or not there is brain reperfusion or reanimation? What are your plans?
So there have been some studies in terms of using Dopplers that showed no brain Dopplers. The other thing is that, as I mentioned, they put a cannula into the thoracic aorta, so above your cross clamp. That cannula basically, so the brain vessels communicate with the thoracic aorta, the cross clamp and the perfusion is below that. That cannula is open to air. So if you're kind of perfusing the organ and there would be brain perfusion or perfusion through that cannula, you should see the column of blood moving. If there is no perfusion, then that column of blood will stay flat. So by doing that and having a cannula open to air that doesn't move, and sometimes people have two heart lines, one in the groin where with the bypass with the perfusion, and heart line in the wrist where it should not be perfused, and ensuring that in the wrist heart line, arterial line, there is no perfusion, and there is some in the bypass or the ECMO. In the ECMO arterial line in the groin. So there's different technique right now that's been done, and there's already different kind of research that have been done looking at brain Dopplers that showed absence of flow during an RP. That will be something similar that we'll be doing.
I don't know how much I am allowed to tell about this, but we're allowed to tell a little bit about this because it's already going on. And it is under research protocols. In our intensive care unit, they actually do invasive brain monitoring and non-invasive brain monitoring. And they have a proprietary device they do this. This actually involves neurosurgery as well. And they actually implant electrodes and probes into the brain in consenting donors. So this is actually happening right now in our ICU to consenting families who consent for this. So there's invasive monitoring to really figure out, when perfusion stops at death. And they've